From the studios of Tucson Business RadioX, recorded in the Stewart Title corporate offices on Broadway, you are now listening to The Mark Bishop Show. And now here's your host, Mark Bishop.
And welcome to another show. You know, there are approximately 155,000 individuals in the U.S. that are living with metastatic breast cancer. Now, up to 11% of new breast cancer cases are initially stage 4 or metastatic. Nearly 30% of women initially diagnosed with early-stage disease will ultimately develop metastatic lesions after months or even years later. And as of 2017 in the United States, nearly 1 in 7 women with metastatic BC were younger than 50. Denise Yardley, medical doctor, is the principal investigator for the Sarah Cannon Research Institute, and we're very honored to have her on the show today. Welcome, Denise.
Thank you.
Denise, it seems while there have been many advances in treatment, this breast cancer remains incurable.
Yes, I think, when I have to sit and share the news of breast cancer coming back and the patient has advanced breast cancer metastatic disease, or the group that comes in and when I'm working them up find that they're already advanced from the beginning, which is about 10%. It's always quite disheartening and news I don't like to deliver, but I quickly partner it with where we are now with the advances in treating these patients with metastatic or advanced stage 4 disease. And while we're not curing them and still waiting for that intervention to be developed, we are treating these patients much like a chronic disease like diabetes or heart disease or kidney disease that we also don't cure, but with the right therapies on board, people are living with their disease and people are living with advanced breast cancer, and we're talking about years. And so, I give them that groundwork and the expectation of excellent quality of life, and that we have these novel developments like KISQALI, which is a pill that keeps patients, out of our office and receiving treatments of chemotherapy and taking a pill in the comfort of their home and expecting that excellent quality of life and being able to function outside of our office in a very predictable fashion. Our expectations when we add this new class of drugs, the CDK4/6 inhibitor, of which KISQALI is one of, and it's a pill, to what was the standard hormone-blocking therapy. When we looked at the trials like the MONALEESA-3 and MONALEESA-7 that had the group that received the standard of care hormone-blocking medicine and the other group received that hormone-blocking medicine and had KISQALI, this novel cancer growth inhibitor, CDK4/6 pathway inhibitor, what we saw was dramatic. We saw the disease control rate, that is, how long could a patient stay on that therapy, double with the group that received KISQALI from 9 to 12 months to almost 2 years before we needed to think about their cancer waking up and changing their therapy. So that gives them an ability to predict, what are they going to look or feel like at Thanksgiving or Christmas or the wedding or birth of a grandchild, because they'll have that expectation that this is the medicine I'm going to be on. My disease is going to be controlled. I'm going to feel like I'm feeling, and I'm going to be on a pill. I can travel and arrange my doctor office visits. And I think even more importantly, perhaps, was that this was a message that translated into our gold standard benefit of improving survival. That is longevity, how long patients are living. So even when the cancer woke up and they received a second-line treatment or third, they benefited up front by their survival in terms of years. So it further improved that. Well,
survival is what a word. I mean, a diagnosis of metastatic or stage 4 breast cancers apparently has a 5-year relative survival rate of about 27%. And despite treatment advancements, metastatic breast cancer continues to take the lives of approximately 113 people every day in the U.S. Is this right?
That's right. And, I think when we look at now being able to talk about time points of years and survival of years, and, for the hormone receptor positive advanced breast cancer, which has a little bit more favorable survivability, those time points really resonate with patients. And, first thing I tell patients, I can't predict.
No.
I do know, when we look at something like KISQALI, I think it's always a concern with patients who present with more worrisome sites of advanced breast cancer, that is disease in liver or lung. And I was fortunate enough to be able to look at the data and present it to the American Society of Clinical Oncology to say, KISQALI is a great drug. It's been active. These 2 trials led to an FDA approval. But what about those that have the most aggressive disease that were treated on the trial, those that have disease in their liver? And we were able to pull out that group and look at the benefit of KISQALI, and it was just the same resounding message of benefit. It's active in the worst sites of disease, giving those patients every expectation to benefit and have survivability and disease control with the addition of KISQALI to their hormone blocking therapy. And so I think, wherever we look, that pathway that drives tumor growth can be inhibited by KISQALI or a CDK4/6 inhibitor and have very predictable benefits for disease control rate and overall survival in patients facing a diagnosis of advanced hormone receptor positive metastatic breast cancer.
I've got a few questions here I want to get in before our time is up. What's the impact of metastatic breast cancer on the lives of patients and caregivers?
I think the impact is the concern that everybody has of a timeline. I think, that seems to be the most dramatic bit of news that I deliver, in that, I don't have a cure rate. The longer I can keep a patient functioning and living with their cancer and turning it into a chronic disease gives us more opportunities to have advances that may be something that I could later offer to the patient. We talk about, this journey of being a person living with cancer and a family living with cancer, and how to embrace that with the focus of the positives in the disease control rates, the positives in the therapies that are not tethering the patients and the families to our office, that they're out living their life in their family community, attending these weddings and births and graduations, and every expectation that we can deliver that with a great quality of life. And if we need chemotherapy, it's there, but it's on the back burner, and we hope to keep it there as long as possible. And so, I think once the family and caregivers can see the patient functioning with treatment and on treatment, I think it really does change that stereotype that we're talking about weeks or months. That's not part of the dialogue anymore.
No.
When we start rolling out parameters of years, I think patients and families are able to step back and say, hey, there are lots of advances, and this isn't like grandma or great grandma who was facing a diagnosis of cancer. This is cancer in 2020, and these are new drugs that have never been around before a year or two ago, standards that have just changed in the last 2 years.
Well, let me ask you about KISQALI, if I can, Doctor. What's the most important
Okay.
information we should know about this? I mean, it causes serious side effects, apparently, including lung problems. It can cause severe or even life-threatening inflammation of the lungs, right? You've got to be very careful with the thing.
So I think with any medicine, that has a host of side effects, luckily at KISQALI, the incidences are very low, but do require monitoring, and that's built into starting a patient on it with frequent office visits, looking for a drop in their white blood cell counts, looking at abnormalities in their heart or their liver, or, very infrequently, but needs to be monitored lung. And I think, we make patients aware of this and symptoms that we want to hear patients report back to us in between the time they're not in our office. And then, when we initiate them for that first cycle or two, and in the first 6 months, we watch and monitor for all of these effects. Most of them, thank goodness, are very infrequent, but we are, very clear about making patients and caregivers and families aware with any medication there are side effects. Luckily, the incidence are quite low, but they are monitored for all of that when they come into the office, and those office visits up front reflect that in terms of frequency. And then when we move out to the patient's been on it longer, we can increase some of the intervals and lessen some of that required monitoring.
Okay, now my listeners can go where to read up on all of this if they want to? Do you have a site that they can go to?
Sure. If they want specific information on KISQALI, the manufacturing website, the www.novartis.com. I always think their healthcare provider is an excellent resource, www.cancer.org or cancer.net or cancercare.org. And patients living with cancer, www.plwc.org is also a great site to, make them familiar with some of the new changing standards and, equip them with the ability to even ask their healthcare providers specific questions. And, is this an appropriate trial or treatment consideration for their disease?
All right. Now, Dr. Denise Yardley, very briefly, because we're going to have to go, but I'd like to know, can you just discuss briefly the results of the analysis that you presented at ASCO 2020?
Yeah. So what I was fortunate enough to present at ASCO 2020 was really looking at patients treated on the clinical trial, MONALEESA 3 and 7, both trials that evaluated a group with KISQALI added to their hormonal therapy, and then a group that just received the standard. And particularly, we wanted to know what benefit those patients that had the worst disease, the most aggressive, life-threatening disease in liver or lung. How did they do with KISQALI? Did they derive those same outstanding therapeutic benefits? And we were able to tease out that population from both of those trials and showed that they derived that same disease control rate when they presented with disease in their liver as compared to a patient who had disease in a bone. KISQALI was effective at both disease sites or in the most concerning disease sites because liver and lung are life-sustaining organs. And so I was able to say, similar to the whole population of the MONALEESA 3 and 7, there was that consistent overall and progression-free survival benefit in patients presenting with liver disease in the MONALEESA 3 and 7 trial. And so, it translates out when a patient presents and they have disease in their liver or lung, which is quite concerning. I feel very comfortable in prescribing KISQALI in those patients, knowing that that has been looked at and the drug is just as effective in that group, and the patient has every expectation to derive clinical benefit from KISQALI added to their hormonal therapy for advanced breast cancer.
Well, it's nice to hear some positive news, and it continues to emerge for advanced breast cancer patients. It's no fun. And I've known people, of course, and I think, every one of us one way in life has been connected or knows of or family member or has, been with somebody who's suffered that. It's not nice at all. Doctor, it's been amazing. Thank you so much. You're very informative. And, well, you should be, I guess. You're a principal investigator, right? Dr. Denise Yardley, principal investigator of Sarah Cannon Research Institute. Thanks, Doctor, and keep up the good work.
Thank you.
Goodbye.
Thank you so much.
All right. Goodbye now.